She's an active educator in the Integrated Endocrinology and Reproductive Health course as a small group leader and lecturer. She's active in the residency education and especially in fellowship, where she gives a number of conferences for the endocrine fellows. She's provided a number of CME presentations as well as some lectures in the community as well. Within the division, department, and school, she's a very good citizen. She leads the combined endocrine conferences for the endocrine fellows. She serves on the endocrine fellowship committee, and she's a member of the compensation committee for the department. Along the way, she earned a number of honors, especially during medical school, including AOA. As a resident, she was named Outstanding Resident Research Awardee at UCSF, and in 2015, she was awarded an Excellence in Endocrine Teaching by the Endocrinology Fellows themselves. Today, we're really fortunate to have Dr. Poehls provide grand rounds for us entitled Challenges in Differentiating Thyroid Cancer, Tailoring Treatment to Fit the Risk. Please join me in welcoming Dr. Poehls.
Good morning, and thank you for that kind introduction and for the opportunity to speak to you today about my livelihood, differentiated thyroid cancer. I'm not sure if many of you are familiar with the ribbon for thyroid cancer, but it is purple, teal, and pink. It's very unique amongst the cancer ribbons out there. So before I get started, I just would like to pose a question to the audience. How many of you have had a patient found or have you diagnosed a thyroid nodule? And of those people, how many of you currently have patients in your practice with thyroid cancer? So amongst various specialties, thyroid cancer is becoming a growing problem. And the goal of my talk today is to discuss the increasing incidence of thyroid cancer and why that might be, but also to equip you with some opportunities to have discussions with your patients in terms of how to tailor their thyroid cancer treatment to fit the varying risks that thyroid cancer poses. These opportunities are present in terms of detection, in terms of treatment, as well as in terms of surveillance of patients with thyroid cancer. Thyroid nodules, as we're all aware, are very common. In a study that looked at the prevalence of thyroid nodules in autopsy, either by palpation or ultrasound, only 3 to 7% of thyroid nodules were actually palpable. However, when an ultrasound was used, the incidence of thyroid nodules varied from 20 to up to 70%. And you can see in this figure that the incidence of thyroid nodules increases with age. This is clinically important because 7 to 15% of these thyroid nodules are harboring a thyroid cancer. Greater than 90% of these cancers are of the differentiated thyroid cancer type, arising from thyroid follicular cells, with the majority of them being papillary, associated with specific nuclear features and papillary formation on pathology. 12% are follicular, which are defined as the lack of the papillary nuclear features, and often evidence of vascular invasion of the capsule or further. And less than 3% are considered poorly differentiated, which are associated with poorer outcomes. This is a graph from the SEER database depicting the increasing incidence of thyroid cancer. It demonstrates the increasing incidence in women, and it shows that the incidence from the 90s has nearly tripled. And it's predicted that in 2019, 3 short years from now, thyroid cancer will be the 3rd most common cancer in women. However, it's important to note that this is an epidemic more so of diagnosis than of disease, because as you see the incidence rising, the mortality remains low, and there hasn't been an increase in mortality following this increase in incidence. The reasoning behind this finding is largely due to the detection of low-risk, incidental, asymptomatic cancers. These are all the nodules that you see on CT reports of the neck or carotid ultrasound reports, and have been classified as the thyroid incidentaloma, an effect of our improved imaging modalities. There have also been changes in how thyroid surgical specimens are being processed and evaluated by pathology, leading to higher detection, as well as the increasing number of thyroid surgeries occurring every year. All of these add to the increasing incidence, but the improved imaging modalities explains the most. So what does it mean when you have a patient who is diagnosed with thyroid cancer? Classically, thyroid cancer treatment included a total thyroidectomy, plus or minus a central lymph node dissection or a lateral lymph node dissection based on the presence of clinically positive or abnormal lymph nodes identified preoperatively or intraoperatively by the surgeon. Most patients, classically in the past, were treated with radioactive iodine, followed by a whole body scan to assess where that radioactive iodine was taken up and to assess the extent or presence of metastatic disease. Following this initial treatment, patients were given supertherapeutic doses supertherapeutic doses of levothyroxine to suppress their TSH, the thought being that differentiated thyroid cancer cells have TSH receptors, and stimulation of those receptors promotes cell growth. And so that is the reasoning behind the TSH suppression. There's very limited role for external beam radiation or systemic therapy when we're talking about thyroid cancer treatment. So one of the problems is that with the increase in the incidence of thyroid cancer, there has been increasing variability in how thyroid cancer treatment or patients are treated. This is another picture from the SEER database that demonstrates majority of patients undergo surgery. That's represented by the light blue. But within approximately 50% will receive radiation for various reasons. And within each subgroup of patients who receive radiation or who don't, there's variability in who undergoes a lymph node dissection. And this holds true for both men and women. One of the reasons why there's so much variability in the treatment for thyroid cancer is that sometimes our treatment for the disease can be more harmful than the disease itself. Risks of surgery include damage to the parathyroid glands that can lead to life-altering hypoparathyroidism. Damage to the recurrent laryngeal nerve can lead to voice hoarseness, difficulties swallowing. There can be chronic pain as a result of this procedure. And so surgery is associated with inherent risks. Radioactive iodine is generally well tolerated. However, it too is associated with risks. It is preferentially taken up by thyroid tissue, but it is also taken up by salivary glands, and that uptake can lead to salivary gland damage, dry mouth, dental caries, nasolacrimal duct obstruction, and there's also a real but small secondary malignancy risk in patients who have received high doses of radioactive iodine. TSH suppression prolonged can put patients at risk for arrhythmia, most notably atrial fibrillation, osteoporosis, fracture, and the risk of having hyperthyroid symptoms, which can be very uncomfortable. So as I've come to learn about thyroid cancer, and as I've reviewed the literature, it becomes very clear that when we are talking about thyroid cancer, one-size treatment does not fit all. And because of all this variability, there have been a lot of organizations that have looked into developing guidelines to help standardize how we are treating thyroid cancer patients across the country. Most recently, hot off the presses this month, the American Thyroid Association published their guidelines for adult patients. They have their own guidelines for children with thyroid nodules and differentiated thyroid cancer. This is an extensive document, over 130 pages long, referencing 1,000 different papers. And I believe this task force did a really excellent job examining the data available and making evidence-based recommendations when possible, and making expert-based recommendations when the evidence is just lacking. And so a lot of my recommendations discussed today will be from this document. The goal of thyroid cancer treatment, as probably with any cancer treatment, is to minimize the potential harm from over-treatment in the majority of patients who have low-risk disease, which includes low disease-specific mortality and morbidity, while still identifying and appropriately treating and monitoring those who are at higher risk. So some opportunities that are relevant for this audience today in terms of how to tailor thyroid cancer treatment to fit the underlying risk involve detection of thyroid cancer, the treatment, and the long-term surveillance. So in terms of thyroid nodule detection, the guidelines clearly state that in terms of screening, there is no benefit to routinely looking for thyroid nodules in asymptomatic patients, particularly those who do not have a high-risk history, which I'll expand upon later. In addition to that, neck ultrasound should not be routinely ordered for patients with abnormal thyroid function tests who are asymptomatic and have a normal thyroid physical exam. I think one of the contributors to the thyroid incidentaloma is the increasing incidence of thyroid ultrasound that is often reflexively ordered in response to abnormal thyroid tests. However, it's important if they have a normal thyroid exam and an otherwise asymptomatic, neck ultrasound is not indicated in the routine evaluation of abnormal thyroid tests. You should consider a neck ultrasound if, of course, you palpate a neck mass yourself or the patient notes a neck mass. A neck ultrasound should be considered if a patient is experiencing hoarseness or difficulties swallowing. These are signs of compressive symptoms commonly associated with large nodules or invasive thyroid cancers. One group of patients that you should consider screening neck ultrasound are those who have undergone head or neck radiation for other cancers, like lymphoma or head or neck cancers. If you have a patient who has a childhood exposure to ionizing radiation from fallout, that would indicate a neck ultrasound, or if there's a family history, that should increase your likelihood to obtain a neck ultrasound. The first step after detecting a thyroid nodule is to check a TSH. because the TSH will help you to decide which imaging to pursue next. If the TSH is suppressed, the first test you should obtain is a thyroid uptake and scan to assess the function of the gland. Then, if a cold nodule is identified, as shown here in the scintigraphy, then you should get a neck ultrasound and pursue biopsy. If the TSH is normal or elevated, then proceeding with a neck ultrasound is appropriate. And once a neck ultrasound identifies a thyroid nodule, nodules should be selected for biopsy based on their ultrasound characteristics. And the new guidelines do an excellent job of really honing in on what are those characteristics that should raise your level of concern for cancer. And I'll go through each one of these categories separately. High-risk thyroid nodules are considered nodules that have a very high incidence of thyroid cancer, up to 70 to 90%. Such nodules often have microcalcifications, these hyperechoic punctate foci, without any shadowing, relative hypoechogenicity compared to the surrounding thyroid parenchyma, and irregular margins. Here's another illustration of a hypoechoic nodule with irregular margins. Features of the nodule being taller than it is wide in the transverse view are also highly associated with malignancy. Evidence of extrathyroidal extension, which doesn't project very well here, but you can imagine that this nodule is poking through the thyroid capsule. Interrupted calcifications, suggesting soft tissue extrusion, and the presence of abnormal lymph nodes in the setting of a hypoechoic nodule should also raise your suspicion. If any of these characteristics are described, any nodule greater than 1 centimeter should be biopsied. Intermediate risk nodules carry a risk of malignancy of 10 to 20%. So you can see the incidence drops dramatically after if those high-risk features are not present. Intermediate characteristics include a hypoechoic solid nodule with regular smooth borders, and the lack of microcalcifications, extrathyroidal extension, or abnormal lymph nodes. Given the risk of malignancy is still 10 to 20% and the risk of the procedure is low, biopsies of nodules measuring greater than 1 centimeter should be considered. This is a depiction of the many types of nodules that are associated with a low rate of thyroid cancer. Low suspicion thyroid nodules carry a 5 to 10% risk of malignancy, and these characteristics include hyperechoic echogenicity, or a brighter intensity compared to the surrounding tissue, isoechoic, or the same intensity as the surrounding parenchyma. And this is where a lot of the mixed solid cystic nodules come into or fall into the risk category. Those that have an eccentric solid component have a relatively higher risk than those without. But again, the overall risk of low-risk nodules, the overall risk of cancer is low. And as such, the size of the nodule at which biopsy is indicated increases. So for low suspicion, we recommend greater than 1.5 centimeters, very low suspicion, greater than 2 centimeters, and if it's purely cystic, biopsy is not indicated. This is just a picture of what I spend a quarter of my time doing every week, thyroid nodule biopsies. At the UW, we do have a multidisciplinary clinic, which has the advantage of the patient getting preliminary cytology. All of the biopsies we perform in this clinic are reviewed, and if the samples aren't satisfactory, we go back and collect more specimen, and we can often give the patient a preliminary diagnosis before they leave. And should we identify suspicious findings. Our clinic is located within the surgery clinic at the same time as the endocrine surgeons, and so the patients can see the surgeon the same day. And so it provides a really nice service for patients dealing with their thyroid nodules. Now, once we do the biopsy, there are several possible results. Majority of the biopsies I perform, up to 80%, come back benign. And the estimated risk of malignancy when a patient has a benign biopsy result is very low, varying 0 to 3%. Approximately 5 to 10% of the nodules we biopsy come back with a suspicious for malignancy or malignant cytologic diagnosis, which is associated with a very high risk of malignancy. And in these patients, surgery is indicated. There is a significant proportion, 10 to 20% of our samples, that come back indeterminate. And the whole concept of indeterminate cytology is a talk in and of itself, including the advent of new molecular testing available for this subcategory. But in terms of this audience, I think it's important to note that if you are faced with a cytologic diagnosis of atypia or follicular neoplasm, these are indeterminate results and further evaluation is necessary. You don't stop here. Often a repeat biopsy or diagnostic surgery is indicated. So what are the goals of initial thyroid cancer therapy? Well, according to the new guidelines, of course, it's to improve disease-specific survival overall, reduce the risk of persistent recurrent disease and associated morbidity, permit accurate staging and risk stratification, and to minimize treatment-related morbidity and unnecessary therapy. One way that we can achieve these goals is by doing proper preoperative staging. And this primarily involves a preoperative neck ultrasound. Preoperative neck ultrasounds in experienced ultrasonographers will identify suspicious cervical lymph nodes in 20 to 30% of patients. And this information will alter the surgery in at least 20% of those patients. CT MRI may be considered, but are not first line. Situations you might consider these imaging modalities is if you have a high suspicion for advanced disease. There's a rapidly growing tumor, rapid progression of hoarseness or dysphagia, or evidence of fixation to the trachea or other surrounding tissues. FDG PET is not recommended in terms of preoperative staging. One of the major changes in the most recent guidelines compared to the last guidelines published in 2009 was the recommendations regarding initial surgical approach. In 2009, total thyroidectomy was recommended for all tumors measuring greater than a centimeter, with or without evidence of local or metastatic disease. The reasoning behind this was thought that it improved survival in retrospective studies, it perhaps decreased recurrence, but it also allowed for the ability to give radioactive iodine. You can only give radioactive iodine if a total thyroidectomy has been given, or should only be given when a total thyroidectomy is performed, and to facilitate future follow-up. Removing the whole thyroid was felt would make it easier to monitor the lymph nodes in the neck and to lower the thyroglobulin levels for monitoring in the future. However, recent data has emerged that demonstrates a similar outcome when comparing total thyroidectomy to lobectomy. But it's important to point out that this is in properly selected low-risk patients. So this isn't for all patients. It's in the patients who have low-risk disease. This recommendation acknowledges the fact that lobectomy may have a higher rate of recurrence. But if that recurrence is properly detected and treated, It does not impact the patient's overall survival in several studies published in 2012, 2014. Accepting the slightly higher risk of regional recurrence may be acceptable considering that lobectomy is associated with lower surgical complications. And this is really important to consider when you're thinking about national guidelines, because 80% of thyroid surgeries in our country are performed by low to intermediate volume surgeons. And of course, when there's a lower volume, there's a higher incidence of complications. However, as my colleague Dr. Hardig pointed out, no matter yesterday at our grand rounds, no matter how high your volume and how experienced of a surgeon you are, there's no surgeon that doesn't have complications. And the complication of post-operative hypoparathyroidism and recurrent laryngeal nerve damage can be very life-altering. Thus, the 2015 guidelines suggest consideration of lobectomy for lower risk patients. This includes patients who have a thyroid cancer less than 1 centimeter without extrathyroidal extension and negative lymph nodes. Lobectomy may be perfectly acceptable for those patients. Lobectomy may be considered, or total thyroidectomy, if the thyroid cancer is between 1 and 4 centimeters without extrathyroidal extension and without evidence of lymph node metastasis. So this is where one of the big changes from the prior guidelines lies. But still, patients who have high-risk features, large tumor or large nodules greater than 4 centimeters, evidence of extrathyroidal extension, clinically apparent lymph nodes, or distant mets, total thyroidectomy is still the recommended treatment. Let's talk talk briefly about lymph node metastases. In terms of thyroid cancer, cervical lymph node metastases is very common. In various studies, when lymph node dissections are performed, anywhere from 20 to 50% or more of patients will have clinically involved lymph nodes on pathology. The most common site of metastasis is the central neck here. That's defined as anterior to the carotid, up to the hyoid, down to the sternal notch. Other more frequent, but after the central neck, levels 3 and 4 are the next most common sites of metastasis. It's important to point out lymph node metastases predicts a poor survival outcome for those with high-risk disease to start. But in patients who have low-risk disease, the presence of positive microscopic lymph nodes does not impact their overall survival. And this will become evident when we talk about the staging for thyroid cancer. There are 2 types of lymph node dissections when we're talking about thyroid cancer treatment. The first is central lymph node dissection. These are either therapeutic or prophylactic. The difference being therapeutic is the intentional removal of clinically involved central lymph nodes, and prophylactic is the removal of non-suspicious central lymph nodes, with the thought being that given the high incidence of lymph node involvement, perhaps removal of these commonly associated lymph nodes will help in decreasing recurrence. However, as you can imagine, the same holds true for prophylactic or central neck dissection in terms of risk of complication. And really, this procedure should only be performed by surgeons that are experienced due to the higher rate of complications, particularly hypoparathyroidism. It should be considered for patients with high-risk disease, tumors with evidence of extrathyroidal extension, or who have clinically lateral lymph nodes. Likely central lymph nodes are also involved. But it's important that information obtained from a prophylactic central neck dissection be interpreted cautiously, because there's a high likelihood that in a patient over the age of 45 who has a higher risk in terms of thyroid cancer, that their stage will be upgraded from a stage 1 due to being an N0 to a stage 3 because central lymph nodes are present. However, the staging doesn't quantify whether these lymph nodes are microscopic or macroscopic. And microscopic nodal positivity does not carry the risk of recurrence that macroscopic nodal positivity does. In terms of, so there's the central neck dissection, and a lateral neck dissection is only indicated when biopsy-proven lymph nodes are detected. Reason being that there's many lymph nodes in our neck, and they're often can appear irregular in nature due to the multiple infections that we're fighting. And that's why biopsy is recommended to prove the disease before proceeding with the dissection. And clearly, when lateral lymph node disease is present, a lateral lymph node dissection will reduce the risk of recurrence and possibly mortality. So after the surgery, you're presented with a pathology report, and there have been specific recommendations in terms of what that pathology report should include in order to aid your assessment of risk and future recurrence. The pathology report should include the tumor size and focality, whether margins were positive or negative, presence of extrathyroidal extension, presence of vascular invasion, and the presence of metastatic lymph nodes, including the number, but also the size and evidence of extranodal extension. This information is used to classify patients using the American Joint Commission of Cancer's TNM system. Tumor size and extrathyroidal extension helps to determine the T category. Presence of central lymph nodes is categorized as N1A. Presence of lateral lymph nodes is categorized as N1B. And then, of course, presence or absence of distant mets. What's important is, under the age of 45, the highest stage a patient can be diagnosed with is stage 2. And that's because this system is very good at predicting mortality, but not very good at predicting recurrence. And the fact is, in patients under the age of 45, mortality from the disease is very low. And so when the disease is diagnosed under the age of 45, stage 2 requires the presence of distant metastatic disease. The rest, all other types of thyroid cancer are stage 1. So you can imagine there is a wide variability of how these patients will progress. Over the age of 45, there are the classic stage 1, 2, 3, and 4, with the stages 1 and 2 primarily being focused on the small, low-risk disease without extrathyroidal extension, and also stage 3, including central neck lymph nodes, stage 4, lateral neck, and more gross extension of the tumor, and B and C, and C including metastatic disease. So again, this staging mechanism provides prognostic information, and it allows for communicating risk amongst health professionals, data registries, but it's not very good at helping our patients on a day-to-day predict their recurrence rates. So because of that, the ATA has come out with a risk stratification system. It first was published in 2009 and has been addended since with the new guidelines, depicting what classifies a low-risk patient versus an intermediate versus a high. So a low-risk patient is a patient who has papillary thyroid cancer with all of the following present: no evidence of distant metastatic disease, all tumor resected, no invasion of surrounding tissues, no aggressive histology like tall cell or columnar, hobnail, other variants of papillary. If a whole body scan has been performed, no radioiodine avid disease outside of the neck or a thyroid bed, and no vascular invasion. Low-risk disease also includes patients who are either clinically N0, no evidence of lymph nodes, or who have clinical N1 disease but have micrometastatic disease, less than or equal to 5 lymph nodes measuring less than 0.2 centimeters. In patients with follicular thyroid cancer, if there are less than 4 foci of vascular invasion, these are also considered to have a low risk of recurrence. ATA intermediate risk category includes those patients who have microscopic invasion into the soft tissue, evidence of foci outside of the thyroid bed on whole body scan, more aggressive histologies like the tall cell, columnar, hobnail, and the presence of vascular invasion in papillary thyroid cancer upgrades it to an intermediate risk. Patients who have greater than 5 lymph nodes, but as long as they are less than 3 centimeters, are still only classified as having intermediate risk. It's not until the lymph nodes are greater than or equal to 3 centimeters that patients have a very high risk of recurrence. Also those with gross extrathyroidal extension into the trachea or other surrounding tissues or esophagus. Incomplete tumor resection, and of course, presence of distant metastatic disease. This is a small proportion of the thyroid cancer patients we see, but it's different. It's important to have a clear description of what these patients' criteria are. Also, follicular thyroid cancer with extensive vascular invasion is also associated with a high risk of recurrence. So when we group patients into these risk categories and look at the incidence of look at the clinical outcomes, majority of low-risk patients have no evidence of disease on follow-up. As the risk increases, of course, the incidence of those without disease in follow-up decreases, but most significantly for those at high risk. In the new guidelines, I'm not going to spend much time going through this, they did a really good job of further breaking down what these high-risk, intermediate, and low-risk pathologies entail, and reviewed the literature and surmised a potential risk of recurrence for these different types of pathologies so that we can better inform our patients about what their real risk of recurrence is. Because you can see within a low-risk category, the risk of recurrence can range from 1% up to 6%, intermediate 3 to 30%, and in high risk 10 to 55 or greater. So what are some of the ways clinically that we assess post-operative disease status? And the reason we're doing so is to determine whether additional therapy is indicated. One of the things that we're using more commonly is the post-operative serum thyroglobulin. Thyroglobulin is a protein made by all thyroid cancer cells. After a thyroidectomy, there shouldn't be many thyroid cells left behind. If thyroglobulin is detected, it's presumed it's either from the thyroid remnant or from persistent thyroid cancer. The nadir of a serum thyroglobulin is 3 to 4 weeks after surgery, and checking a post-op serum thyroglobulin can help assess how good the surgery was, how much remnant was left behind, but also to help predict the risk of recurrence, particularly if that post-operative thyroglobulin level is greater than 10. We often use this value to help us to determine whether to use radioactive iodine The goal of the radioactive iodine being to make that thyroglobulin level undetectable. However, the cutoff value to prompt, the absolute cutoff value to prompt radioactive iodine treatment is not known. And clinically, it's better at helping to identify patients whom need radioactive iodine, but then from who do not need radioactive iodine. The post-op thyroglobulin can help to confirm a low-risk category if the non-stim or stimulated thyroglobulin is less than 1. However, an intermediate risk, a non-stim or stimulated thyroglobulin of less than 1 is reassuring, but it's still possible in patients with intermediate risk disease to have small volume radioiodine avid metastatic disease. And so if their initial risk is intermediate because of extrathyroidal extension, radioactive iodine may still be necessary. And this is a detailed slide that I won't go into, but it just illustrates the decision points in terms of when to decide or how to decide the use of radioactive iodine. With low-risk patients not routinely having radioactive iodine recommended, intermediate risk patients generally favoring radioactive iodine, and of course patients with high-risk disease, radioactive iodine is favored. When giving radioactive iodine, there are also opportunities to tailor that treatment to the patient. That includes when determining the dose. Patients who have intermediate or risk disease or low-risk patients choosing to have radioactive iodine, a low dose of 30 millicuries of I-131 may be used to minimize the risks of the radioactive iodine. Of course, high doses are determined and calculated based on, or for high-risk patients, based on age, size of tumor, lymph node involvement, and other factors. In order to prepare patients for radioactive iodine, it requires TSH stimulation. In the past, this was performed by having patients withdraw from thyroid hormone for 3 to 4 weeks so that their TSH would rise naturally with a goal of TSH greater than 30. Over the last 10 to 20 years, there has been recombinant human thyrotropin available, or synthetic TSH, so that patients don't have to go through thyroid hormone withdrawal. Recombinant human thyrotropin is primarily indicated for low-risk, intermediate-risk patients. Thyroid hormone withdrawal is still generally recommended for the high-risk patients. And then, of course, timing is also can be tailored to your patient's situation. There's a lot of patients whom I have, young women who are diagnosed during pregnancy or shortly after delivery, and who wish to continue breastfeeding, and breastfeeding is a contraindication to radioactive iodine, and so the timing of the radioactive iodine can be tailored for that individual patient. The last part of initial thyroid cancer treatment is TSH suppression. And the degree of TSH suppression should be tailored to the patient's risk. Patients who have high risk disease should have a TSH suppressed to less than 0.1. However, those who have intermediate or low risk disease do not require such significant suppression. Intermediate risk should have a TSH goal of 0.1 to 0.5. Low risk, particularly if all they had done was a lobectomy, low normal range is sufficient. However, until you can demonstrate that the thyroglobulin levels are low, it is reasonable to use a TSH goal of 0.1 to 0.5. But once low thyroglobulin levels are demonstrated, low normal range is sufficient. So the last part of the talk, I'd like to talk about how we need to modify these risks that are determined initially based on how the patient responds during follow-up. And the guidelines really emphasize that that initial risk needs to be continually modified because the risk of recurrence and disease-specific mortality changes over time as a function of the course and the patient's response to therapy. So whereas initial risk guides initial management, a response to therapy assessment should guide your ongoing management. And when we're evaluating response to therapy, we're primarily looking at those serum thyroglobulin levels and neck ultrasound. In patients who've had radioactive iodine and had abnormal uptake, you may consider a whole body scan, particularly those with intermediate or high risk disease. And if these studies are unrevealing, then one might consider CT or PET. But these are not used outside of patients with high risk disease very frequently. So there have been several studies describing a way to classify therapy response. The first being an excellent response, meaning no evidence of disease. The second, a biochemical incomplete, meaning an abnormal thyroglobulin with negative imaging. Structurally incomplete response, meaning persistent regional or distant metastatic disease. Or an indeterminate response that signifies nonspecific biochemical or structural findings that can't be classified as benign or malignant. These risk stratifications are very useful when on a day-to-day practice, but it's important to note that due to the nature of thyroid cancer and the fact that it takes many years of follow-up to determine effect of an intervention, there's a lot of, the strata lacks validation in studies, lacks prospective data, and there are inconsistencies amongst the literature, and it also assumes that you have access to high quality biochemical testing and imaging. And so there are limitations to this system, but it helps to tailor your treatment for your patient. So in terms of excellent response, patients who are defined as having no evidence of disease have an excellent clinical outcome, 1 to 4% risk of recurrence, and less than 1% disease-specific mortality. So if you can tell your patient they have had an excellent response to therapy, they can feel reassured that their risk of both recurrence and of death is low. And because of this, it allows us to decrease the intensity and frequency of follow-up in terms of the number of imaging and the number of lab draws, as well as the degree of TSH suppression. When a patient has a biochemically incomplete response, which is defined as negative imaging but a positive thyroglobulin, suppressed greater than 1 or stimulated greater than 10, or the presence of rising thyroglobulin antibodies. Overall, majority of these patients do very well. 30% will resolve to no evidence of disease, and 20% will achieve no evidence of disease with additional therapy. Only 20% of this category will go on to develop structural disease, and less than 1% of patients in this category will have disease-specific death. So in terms of management, these patients can be followed, their thyroglobulin levels can be followed without further intervention until there's evidence of course, structural disease or evidence of a rising thyroglobulin. Patients with structurally incomplete disease tend to have the more poor outcomes. 50 to 85% have persistent disease despite additional therapy. And disease-specific death rates are higher in this group of group of patients. 11% risk of disease in those who have local metastatic disease, and 50% with distant disease. So in patients who have a structurally incomplete response, these patients need to be followed more closely than patients with other responses. And sometimes that means just continued observation, but additional therapies can be decided upon based on rate of growth, radioiodine avidity, and the specific pathology. An indeterminate response is kind of the catch-all category for patients that don't fall into the other three. It's those that have non-specific findings on imaging that haven't been defined as recurrence, those that have non-stimulated thyroglobulin levels or stimulated thyroglobulin levels less than 10, and in these patients, 15 to 20% will go on to develop structural disease in the future, but the vast majority will have these changes either remain stable or resolve. And again, in this category, there's less than 1% disease-specific death. And so in terms of management, in patients who meet the criteria for indeterminate response, continued observation is appropriate, intervening when specific findings become more suspicious. And this is just to illustrate that once you're able to determine response to treatment, that can help to tailor your TSH suppression, because TSH suppression is associated, as mentioned before, of arrhythmias, osteoporosis, atrial fibrillation, hyperthyroid symptoms. And if someone has an excellent response, there's no indication for TSH suppression. However, anyone who still has structurally incomplete disease or higher risk should have their TSH suppressed to less than 0.1. So my take-home points today that I hope you remember after today are that the thyroid cancer incidence is increasing, and that there is no one-size-fits-all treatment in terms of thyroid cancer treatment. There's an initial risk assessment that helps you determine initial treatment, and a dynamic risk stratification during follow-up that determines future surveillance and treatment. And all along this process, clinical decisions must balance the risk of recurrence and disease-specific mortality with the potential benefits and risks of the therapy and surveillance. And these are just some resources if you do have patients with thyroid cancer to refer to that are reputable and have a lot of really useful information.
Thank you very much, Dr. Poehls. I'll ask you to call on the audience. We've got a few minutes for questions.
Anne?
So, excellent talk. I think it's going to be a hard sell when I have an asymptomatic patient and I feel a nodule in the thyroid, both for me and the patient not to do an ultrasound. So I might think, well, maybe there's more there and I'm not talented to feel it. Once the patient kind of realizes that I'm feeling something, they won't believe that I'm not doing anything. What's your approach to that?
Well, I'm sorry if I misspoke, but if you do palpate an abnormality on neck exam, neck ultrasound is indicated.
It's fine.
Yes. It's the situation where, correct, just general screening of all patients with abnormal thyroid test is not indicated. But if you palpate an abnormal thyroid, by all means get a neck ultrasound. There,
And can you do the, you also indicated about waiting till the thyroid test came back, but reality, I'm probably going to do both at the same time.
right. I think I can definitely understand that from a practical standpoint, day to day. Oh, thank you. So in terms of the timing of lab and imaging, in a day-to-day practice, most often it's more practical to order both the TSH and the neck ultrasound. And probably 9 times out of 10, since majority of the TSH values will be normal or elevated, that's fine. I think it's just important that usually the TSH is going to come back before the neck ultrasound. And so if the TSH comes back and it is suppressed, I would urge you to consider getting that uptake and scan at that point. And it's fine to, if you ordered the neck ultrasound because you palpated an abnormality, it's fine to keep the ultrasound. But I just think it's important to have that uptake in scan when the TSH is suppressed, because one of the things with thyroid nodule biopsy is we tend to try to avoid biopsying hyperfunctioning areas, because biopsies of those areas tend to give false positive results. And so that's why it's so important when a patient has a TSH that is suppressed that we have an uptake in scan so we know where not to biopsy. Yoram.
Great talk, Jennifer. How long would you continue doing thyroglobulin and ultrasound on someone who's low risk and has excellent response?
That's an excellent question, and the guidelines are very vague about that. I think it depends on, how long do you follow patients with excellent response? I think it really has to be tailored to the patient and the initial, which would include both the initial pathology of that low-risk patient, because even within that low-risk patient category, there are patients that have microscopic disease, but there are also patients that have large-sized tumors with several microscopic lymph nodes. And so it really depends on how quickly their thyroglobulins were negative, if there was any suspicion during that initial follow-up. But I think it really has to be tailored to the patient and their clinical course.
We're going to have to close it right there. I want to thank Dr. Poehls for presenting an outstanding grand rounds.